Hello, my name is James Gilmore. I'm a clinical pharmacy specialist in critical care at Brigham Women's Hospital, and I'm here to discuss critical care pharmacology. As far as disclosures, I've served in a consultant role on an educational advisory board for Pacira Pharmaceuticals Incorporated. The objectives of this discussion today are to describe the principles of pharmacokinetic and pharmacodynamic, to describe the changes in pharmacokinetics associated with critically ill patients and their impact on pharmacodynamics, describe ways to optimize pharmacokinetics and pharmacodynamics in critically ill patients, and to discuss alterations in pharmacotherapeutic response due to acute illness. So first, I'd like to review the principles of pharmacokinetic and pharmacodynamic. They're often thrown around and said, but it's important to actually understand the difference between the two. So pharmacokinetics is the study of the time course of drug absorption, distribution, metabolism, and elimination, which we'll get through each of these individually later. And it's most simply referred to as what the body does to the drug. And so here's our graph of concentration over time after administration. And the difference here to pharmacodynamics being more the relationship between drug concentration at the site of effect and the resulting effect, simplified to think of as what the drug does to the body. And together they come together to look at our PK-PD relationship, which is essentially the effect of the drug on the body over time, and is here displayed graphically. Now this is a busy slide, I know, but I think we like to focus on essentially the two most common pharmacokinetic changes in critical illness, and they will come first with variations of extracellular fluid, which you'll often see in patients who are edematous or getting a lot of fluid, say in the initial phases of sepsis, and that can often lead to drug dilution or loss. And so in these types of patients, we would consider increased dosage of medications. The second most common pharmacokinetic change in critical illness is the variations of renal clearance, and those can go up and down depending. Most common acute kidney injury, say, would decrease our renal clearance, and in these cases we might have to consider dosage decreases, but there are some cases, say like burn patients, although that kind of goes into the extracellular fluid as well, where there might be enhanced renal elimination and we might need to consider dosage increases. So, like I said before, pharmacokinetics is the study of absorption, distribution, metabolism, and excretion. So we're going to go through each of these individually and discuss what sort of changes we might see in critical illness. So we'll start with absorption. And dictionary definition, I guess, would be the extent of substance moving into systemic circulation from the site of administration. And it's tied pretty heavily to bioavailability. F is the medical fraction of drug administered absorbed definition, and it's obviously got a wide list of variables that could influence the bioavailability of medication, such as tissue perfusion, the membranes across which they have to be absorbed, and the drug properties themselves, so lipophilicity, the size, and the ionization. Our perfect route of administration as far as absorption is concerned is intravenous, which has got 100% absorption. And then every other route of absorption has the potential for non-complete absorption. So PO most commonly, we have the fraction of dose absorbed, which is going to be dependent upon gastric motility, solubility, acidic versus basic environment, and we're up against intestinal first-pass extraction and hepatic first-pass extraction, saying that maybe not an entire dose administered could reach the active site in the body. And here are other common routes of administration, some of which are very good and may reach high levels of absorption, but will likely not be as good as the 100% absorption we'd receive with intravenous. To give you an idea of kind of real-world applicability, I'll use sepsis as an example several times throughout this presentation. So absorption differences in sepsis, we'll see altered perfusion with shunting blood away from several absorption sites, hypovolemia, and the use of vasoactive medications, using as an example to decrease perfusion and thus absorption. pH changes, the intestinal motility dysfunction, and interactions with enteral nutrition will also play a role in decreased absorption. So here is a just question just to think about which of the following is a common mechanism by which drug absorption is altered in critically ill patients. 1, increased blood flow to the small intestine. 2, increased gastric emptying. 3, decreased gastric pH. And 4, decreased blood flow to subcutaneous tissues. And so the answer here would be 4, decreased blood flow to subcutaneous tissues. The other 3 are incorrect. Number 1 there likely be decreased blood flow to the small intestines due to shunting, decreased gastric emptying, and likely an increased gastric pH. And that could be due to the disease state or, say, medications used for stress ulcer prophylaxis. So I'd like to kind of display the real-world consequence of this decreased blood flow to subcutaneous tissues here in a couple of slides. First, we want to cover just the overall role of shock and vasopressors on absorption because they will shunt blood towards our most vital organs, the brain, the lung, and the hearts, and thus leaving some of the non-vital organs diminished in blood flow, so the GI tract, the subcutaneous tissue, and the absorption will be diminished due to that decreased blood flow. So the routes that are going to be most affected here are enteral absorption, transdermal, sublingual, IM, and sub-Q. Gastric emptying will also play a role here. There will be decreased gastric emptying in approximately 40 to 60% of critically ill patients. And if we look at these different subpopulations of the critically ill, they'll all be at high likelihood of experiencing some level of delays in gastric emptying. And since most medications are absorbed, at least when they're administered enterally, in the small intestine, we'll see likely a delayed peak and a delayed onset of action, and in many cases even a reduced peak. So a good rule of thumb is often to ensure that these critically ill patients are tolerating tube feeds prior to changing medications from intravenous routes to an enteral route. And speaking of tube feeds and the feeding tubes in general, that while we are using them to administer medications often in the critically ill patients, they will themselves lead to decreased absorption. And so the medications will often stick to the plastic in the lumen. So that's why it's a good rule of thumb to always be sure that the tube is being flushed with water before and after administration to try to maximize the amount of drug that's actually making it into the intestine. Increasing gastric pH, and there are some drugs that require an acidic environment to actually be absorbed. They're not necessarily the most common drugs that we use, but say drugs like itraconazole will require an acidic environment to be absorbed, and if patients here are on stress ulcer prophylaxis that are going to raise their gastric pH above 4, it might not necessarily allow the medication to be absorbed. Other problems with the feeding tubes is in the tube feeding themselves. The components of the enteral feeds have the potential to bind drugs and so that they won't be absorbed. So drugs like phenytoin, warfarin, tetracyclines. In phenytoin, it's recommended to hold tube feeds for an hour before and 2 hours after the administration of the dose. And so if you think about phenytoin, who could often be administered 3 times a day, that could lead to, say, 9 hours of the day being held for administration of phenytoin, and then you could sequentially now be having the patients not meet their caloric needs. So in patients like that, it might be worth considering or discussing with your dietitian the possibility of either changing to a bolus tube feeder regimen, or if you think the patient's not going to tolerate bolus tube feeds and you want to keep on continuous and not have these interruptions, you could switch the phenytoin to an intravenous formulation. So here are some examples of the decreased absorption of one of our most commonly used agents. These are the low molecular weight heparins, are enoxaparin, dalteparin. So first I want to compare basically the effect of critical illness, being in the ICU in general, and then the next slide we'll talk about when we start to use vasoactive medications. So here we can see on the left, these are patients in the ICU who are not on vasopressors. And on the right, we're comparing that to patients who are not in the ICU in general. So we can see, there's this is a small trial naturally, but there's a slightly decreased peak. But overall, the critical illness in general is not a huge impact, but we're definitely seeing a decrease in the AUC of the medication. But then when we compare that to patients who are in the ICU on vasopressor medications, now here on the right-hand side, we're seeing not only a significantly decreased peak at the 3-hour mark, but also, just very, very poor absorption to the point where you have to question what sort of efficiency we're really getting out of subcutaneous DVT prophylaxis in patients who are on vasoactive medications. The same is true in patients who are considered edematous, administration of low molecular weight heparin. In non-edematous patients, you can see we have this nice clear anti-10A curve of activity in patients who are non-edematous, but in edematous patients, again, decreased peak and a shortened duration of action that definitely makes it questionable when you have to think about the absorption in these patients. And this isn't just unique to the low molecular weight heparins. You can apply it to really any subcutaneous medication, most common of which being insulin, which is why I think, and we'll discuss later, but a heavy push to use intravenous insulin in the ICU because we want to actually be confident in the amount of insulin that's reaching the patient therapeutically. Now, I've said a lot about, say, decreased absorption in critically ill patients on vasoactive agents. It's not necessarily the case for all agents. Some agents have very good absorption even in the presence of vasoactive medications and critical illness. So an example of that is oseltamivir, so Tamiflu. So this is a study looking at 41 adult ICU patients with H1N1 influenza who were treated with oseltamivir. And so 75 milligrams twice a day achieved plasma levels in these patients comparable to those in the ambulatory settings. So, and you look at these aren't, the most sick, but they are actually pretty significantly sick. So we got Apache scores of 19, 32% are on vasoactive agents. And I think it's enough to say confidently that if we're able to have a tube in and be administering oseltamivir in the ICU, we can be pretty confident in its absorption. Moving on from absorption to distribution. Distribution is definitely influenced by a lot of different variables, the patient's weight, fluid status, adipose tissue, and as well as drug variables, the lipophilicity, molecular weight, and then the affinity for plasma proteins and tissues. So the most common distribution change we'll see in critical illness is capillary leakage. So it's common in all types of the systemic inflammatory response syndrome, which is not just for sepsis anymore. Obviously, with trauma, CERN, surgery, burns, and pancreatitis patients will all appear SIRSI at times, and as such experience that capillary leakage. The endothelial cells lining the capillaries begin to separate, and so then the fluid and plasma proteins leak from the intravascular space into the interstitial space. Other times where distribution will be altered is the heavy-duty fluid resuscitation that we're also administering to patients when they are common in SIRS and shock and are meeting our SEP1 goals of 30 mLs per kg of crystalloid in the first 6 hours will drastically alter the distribution of many medications. It'll increase our plasma volume, and as such, hydrophilic medications will remain primarily in the plasma water volume, and that will result in decreased serum concentrations of beta-lactams, aminoglycosides, and vancomycin. And so in these cases, what we'll often do is try to dose aggressively up front, either considering a loading dose or maybe a first dose that's higher than what we would consider for the patient's renal status, just to try to get us to our pharmacokinetic goal early with these time-sensitive medications. Other things, so now we've talked about altered volume and distribution, but also other distribution factors is the changes in plasma protein binding. So acidic drugs in general, such as phenytoin, will bind to albumin, and basic drugs like morphine will bind to AAG, the alpha-1 acid glycoprotein. But in general, I think the plasma protein binding concepts apply to both, so that hypoalbuminemia is common in critical illness, so we'll see increased vascular permeability, decreased hepatic production, and then a shift to acute phase reactions, and so protein catabolism. Unbound drug concentration often will be what mediates therapeutic drug side effects. So often you see patients come into the hospital and they're on warfarin, for example. Warfarin's a heavily protein-bound medication, and so heavily bound to albumin, and the unbound warfarin is what in fact leads to the therapeutic changes on the INR. So these acute shifts that could happen when they come into the hospital could suddenly release a lot of warfarin from the protein, and so then thus acutely raising the INR because of the amount of unbound warfarin. So here another drug, I said warfarin, but another one that we'll often common see, mostly in our neuro population, is phenytoin, significantly bound to albumin. And we have the luxury with phenytoin of doing a lot of therapeutic drug monitoring, but the key is to know which phenytoin level we should monitor. So a goal total phenytoin concentration is 10 to 12, except that 10 to 12 has to be adjusted for hypoalbuminemia. So there are calculations you can do to try to account for the difference from the patient's serum albumin from a normal albumin to try to correct for it. but we have the luxury of also trying to be able to monitor goal-free phenytoin levels. And I think in critically ill patients, septic patients, it's important to monitor free levels in critical illness. We can monitor the total serum, the common, the 10 to 20, but the free level might give us the most up-to-date data to use. Another decreased drug effect with hypoalbuminemia, ceftriaxone, is a drug that I don't think gets mentioned a lot in patients who are hypoalbuminemic, but it's actually about 95% bound to albumin, and so it has extremely quick clearance in patients who are hypoalbuminemic. So in those patients, it may be worth considering doing, say, ceftriaxone 1 gram Q12 as opposed to 2 grams once a day if you're using that high of a dosing to try to maximize the effect of the ceftriaxone. Next on distribution, things that may be impacted is tissue perfusion in distribution in critical illness. Regional tissue hyperperfusion is common in critical illness, and that's kind of potentiated by things that we've talked about before: capillary leakage, tissue edema, microvascular failure. And in these cases, we'll often see decreased delivery of hydrophilic medications by the blood to the capillary beds. Most commonly, things that I think we'll see the most is antibiotic penetration into these tissues during septic shock is drastically decreased, say 5 to 10-fold. And so to kind of sum up the changes in distribution in critical illness, thinking it's not all one change. There are going to be changes that are increased volume distribution, changes that are decreased, so that's where it's important to consider the differences in our disease states. So we'll see an increased volume of distribution in shock states, particularly, say, the early stages of septic shock when we're doing massive fluid resuscitation, also heart failure, again, fluid, different mechanism, but malnutrition will really lead to less protein for which drugs to be bound to. Overall, these will lead to decrease in serum concentration, and decreased volume and distribution, which will lead to an increase in our serum concentration, can often be as patients start to recover from their acute ailments. We may need to consider changes in drug levels because of the now slowly decreasing volume of distribution. Other disease states where we'll need to increase our serum concentration will lead to an increase in serum concentration is hypovolemia and inflammation. Here are some graphic examples of that decreased penetration into end tissues. So vancomycin, I think, is the classic one because I think a lot of providers will think, okay, I want a goal of 15 to 20 for more severe infections. And it's not necessarily about maximizing the AUC to MIC in general, but specifically, we look at actually how much vancomycin is reaching the therapeutic goal or the tissue of the site of infection. And really what we're trying to do is maximize the pharmacokinetic and dynamic relationship at the site of infection in pneumonia. So for this, we say we have a therapeutic level of 20. Actually, in the lungs, we're most likely actually only getting 25% of that. And if you think about our pharmacokinetic and dynamic goals for vancomycin, we're trying to establish an AUC to MIC relationship of over 400. So that's why we really want to get serum to 20, is because we're actually trying to get really what we'd consider subtherapeutic levels in the serum, but actually as good as we're going to get likely into the lung tissue. And the same can be true for the CSF if we're treating, say, meningitis and vancomycin is being used. Again, really to try to get to similar levels, 20 to 25 may actually be more appropriate to get us better serum levels at the site of infection than just the usual considered 15 to 20. Moving on from distribution to metabolism. Metabolism is defined as transformation of the parent compound into metabolites, and primarily that is done in the liver, but there's also some lesser metabolism that's happening in the GI tract, the kidneys, the lungs, and the brain. And the alterations in metabolism that we'll see is actually threefold here. Largely is changes in hepatic enzyme activity, changes in protein binding, and changes in hepatic blood flow. So metabolism, hepatic blood flow, there are disease states that will increase hepatic blood flow and thus increase metabolism. That's the early stage of sepsis. So as we're in a compensatory state, increased cardiac output, our hepatic blood flow is going to increase. And so early metabolism is going to increase. And so again, we might need to consider increased medication use in the early stages of sepsis. Vasodilator use and ionotropes may also increase our hepatic blood flow. And we think about disease states that would decrease hepatic blood flow and thus decrease metabolism. later sepsis, so we've started to run out of gas on the cardiac output, hypovolemic shock, myocardial infarction and acute heart failure, and vasopressor use will all lead to decreased hepatic blood flow and thus decreased metabolism. Hepatic enzyme activity is something that's talked about a lot, so many critically ill states will result in this increase in hepatic metabolism, so TBI, burn patients, patients who essentially burns getting a lot of fluid, it's going to force, sorry, let me say that again. Let me take this one over. Do you need the slide number? Yeah, it's 30.
Okay, thank you.
Okay, so metabolism, speaking of hepatic enzyme activity, some critically ill states will result in decreased hepatic metabolism, so TBIs and burn patients, but likely decreased activity of CYP 450 enzymes on their own will occur in the stress response and be what we see most of, so that'll prolong the effects of parent compounds, reduce the effects of prodrugs, and increase toxic metabolites. Protein binding, again, we're talking about hypoalbuminemia here, so like we mentioned before, unbound drug concentration will happen. More often we'll see higher concentrations of unbound drugs, the protein-bound drugs in these shock states, because we'll often be hypoalbuminemic or say they're malnutrition. Unbound drugs with the high hepatic extraction ratio will be metabolized more quickly, and so that's drugs like diltiazem, fentanyl, haloperidol, methylprednisolone, propofol, a lot of heavy hitter drugs that we see a lot in the intensive care unit will be metabolized more quickly. So hepatic metabolism is broken down into, in general, 2 phases, and they're different subsets, but I think the easy way to try to remember them is generally phase 1 is oxidation, reduction, hydrolysis, but phase 1 largely is in conjunction with the CYP enzymes, and phase 2 is, say, less fluctuating. The glucuronidation is our most common phase 2, but there's still some major drugs that use conjugation and methylation. CYP, or again our phase 1 hepatic metabolism, located primarily in the liver, obviously will be affected by liver failure and liver disease, and can contain some genetic polymorphisms, so that'll alter metabolism, increase metabolism, prodrugs. A lot of, say, genetic polymorphisms that we can see will be in medications like clopidogrel. In the Asian population, there's a lot of altered pharmacokinetics of clopidogrel. But really the moneymaker and the things to remember with the CYP isoenzymes is the drug interactions. It's important to be aware of what medications your patients are on that are CYP substrates, and then what medications are inhibitors and inducers, because we can often have drug interactions be happening in front of us related to altered metabolism, not necessarily be aware of it. So these are, to kind of graphically summarize, some medications that are going to influence our hepatic blood flow. It's, again, physiologically it makes sense. So some medications like nitroglycerin that would, say, vasodilate would increase our hepatic blood flow. Some medications that are more clamped down, like epinephrine and norepinephrine, phenylephrine, will lead to a decrease in our hepatic blood flow because of that alpha activity to clamp down. CYP, to give a kind of graphic interpretation of how many different drugs are going to be impacted by these changes. Here on the left-hand side are our common CYP substrates. So these are drugs who have a metabolism that is rooted in the CYP isoenzymes. Inducers of CYP metabolism, they will speed up the metabolism and thus make the original drugs, say, have less of an effect. Inhibitors will reduce the metabolism of the substrate. So as we look through some common things that will occur, so some common substrates, fentanyl, midazolam, morphine, phenobarbital, warfarin, these are all substrates and not necessarily things we think of, but things that could cause drastic changes in, say, warfarin absorption and warfarin action if patients are on rifampin. Or say I have a patient in the surgical ICU who's on fentanyl, midazolam, and it's decided to empirically start fluconazole. That beginning of fluconazole could drastically inhibit the metabolism, causing a supertherapeutic effect of the benzodiazepine and the analgesic, and that could lead patients to be at an increased level of sedation and not keep them at, say, the typical RASS goal of 0 to -1 that we'd want to keep them at. Moving on to our final pharmacokinetic parameter is elimination. So with elimination, I think there's some important terminology. So there's half-life, which obviously this first half-life is not the most important part to remember, but the half-life is considered 0.639 over the excretion constant. But what's more important for you to really remember about half-life is, say, that 97% of the drug is eliminated by 5.5 half-lives. So knowing the half-life of a drug isn't necessarily going to mean in one half-life it'll be gone. It's actually going to be 5 half-lives. And also when starting a medication, it's going to require 4 to 5 half-lives to reach the steady state of that medication. So even if they're short-acting medications, it might take a while to reach a therapeutic effect. Clearance is the volume of plasma, serum, or blood cleared off the drug per unit of time, and this largely happens in the kidney and the liver. So overall, it's just to talk about some alterations in liver disease patients, because they will see main changes throughout the board. So kinetic changes, we'll see decreased hepatocytes, decrease in hepatic blood flow, decreased albumin synthesis, impairment of renal function, and increased volume of distribution of hydrophilic drugs. And pharmacodynamically will alter our blood-brain permeability and alter the receptor response. So liver disease will change things across the board. And the same is true, we progress that onto cirrhotic patients. Plasma protein binding will be reduced, but this can have variable effect on the drug half-life. It can be, say, the reduced half-life if the patient maintains hepatic enzyme activity, but it could also be increased if the metabolic capacity is reduced. Binding changes, these are relevant for our highly protein-bound drugs, things we mentioned before, so phenytoin and warfarin. Metabolic capacity, so the phase 1 is often affected greater than phase 2, and that's true in cirrhosis and in acute liver injury. So our, say, acute shock liver, we might see more of an impact in our CYP metabolism activity as opposed to our phase 2 glucuronidation activity. That will likely take much more liver damage to impact a glucuronidation metabolized medication as opposed to CYP. Now, how do we assess liver function as far as the pharmacokinetics go? It's very difficult for applying these assessment of liver function to medications. The current classification schemes, Childs-Pugh, MELD, there's not great sensitivity to quantify liver metabolic capacity. There are some medications that actually do have dosing suggestions based on Childs-Pugh scores, but they're few and far between. It's largely kind of an approximation. I think you have to use it as a piece in a bigger picture, looking at the presence of cirrhosis, our synthetic function, and if the patient's encephalopathic, they're good markers to see how the liver could be functioning in general, but it's difficult to know exactly what impact that's going to have on the drug. That's where it's good to try to consult the unit-based pharmacist to give some sort of insight into how the medication may be affected, as well as maybe a therapeutic monitoring regimen. Dose adjustments, it's like I'm saying, consulting the pharmacist to say, is this a high or a low hepatic extraction ratio drug? Because they can help with maybe, do we need to decrease a loading dose, decrease a maintenance dose, or do we need to give a bigger loading dose or a, say, decreased maintenance dose? It's difficult because there's very few medications that are based solely on a Childs-Pugh classification when it comes to dosing, and really plasma drug level monitoring is the best bet. Unfortunately, so many medications that we know could have side effects that are related to overdosing. We don't have a great way to therapeutically monitor them, and if we do, sometimes they're send-out labs. Things like voriconazole, for example, we can send a voriconazole level and we'll get it back in 3 days, and so what could we be doing in the meantime? Overall, let's talk altered metabolism in sepsis. Our hepatic blood flow is increased in the early phase, decreased in the late phase, and the protein binding is going to be increased for the AAG, so our basic drugs, and decreased for albumin. So on to just talking about renal elimination. There's a number of ways we can assess renal elimination. We talked about it, and so I'm just going to float through some variables here. There's the glomerular filtration rate. There's creatinine clearance, the rate of urinary creatinine excretion over serum creatinine concentration. Here's one calculation of how to determine our creatinine clearance in milliliters per minute. Here's a more common one that we'll use, the 140 minus the age multiplied by the ideal body weight over 72 times serum creatinine, and then we adjust for gender. And then there's using serum creatinine in a vacuum, which I'll often see get used, but it's a difficult variable because it's just one moment in time, so it's important to really examine trends, and I think in the ICU we have a lot more dynamic variables to assess renal elimination, things like urine output. Creatinine clearance is theoretically the way we're supposed to dose drugs, as many drugs in the package inserts are based on creatinine clearance, but it's difficult in many cases because the serum creatinine is going to be rapidly changing, and so the creatinine clearance, you're going to be lagging behind a lot of the time, so using more dynamic variables like urine output may be helpful. But certainly serum creatinine in a vacuum, if we look at, say, patient is 0.8 in the evening, and then first thing in the morning we're 1.4, we know we're in an acute renal failure situation. So to review some more changes in renal excretion, so we'll see decreased renal elimination due to cases like acute kidney injury, hypovolemia, and increased biliary elimination. And decreased elimination will necessitate kind of consultation with the pharmacist and necessitating medication dose frequency adjustments, because overall that's why we have pharmacists in the ICU to try to monitor for these acute changes and try to avoid the adverse events that may happen in supertherapeutic concentrations. Most drugs are eliminated via the kidney. Acute kidney injury, like I was just saying, is extremely common. Depending what you read, up to 25%. Some could argue it's higher. The metabolism and excretion of medications will often be decreased in critical illness, or just decreased renal function in general. Here's an example of a semi-commonly used medication, dabigatran, sort of fallen out of favor lately as compared to oral anti-10As, this oral DTI. If we look at patients who are, say, having a relatively good over 80 creatinine clearance, administered a 150 milligram dose, we can see kind of a lower peak clearances happening as predicted. We're dosing by 12 hours, we're decreasing, and so as steady state over time would be good. But so we look at patients who are, say, creatinine clearance less than 30 or an acute renal failure situation, our peak is substantially higher, about 4 times higher, and the clearance is also going to be decreased, and we're getting down to that point of between at around 72 hours, at the same point we'd be at 12 hours in patients who are creatinine clearance over 80. So finally, I want to run through some examples of how we commonly optimize the pharmacokinetic and dynamic relationship in critical illness, and these are the things I think you'll often see the unit-based pharmacists talking about because there are tried and true ways to optimize kinetics. So first is the prolonged infusions of time-dependent antimicrobials. Second is intravenous insulin, and the third is protocols for sedation and spontaneous awakening trials. So just as a matter of review, this is not an ID talk in general, but largely talking about the pharmacokinetic goals of many antimicrobials. I would say most patients have an antimicrobial regimen that's based around a beta-lactam backbone. And most of these beta-lactams are time-dependent antimicrobials, so our cefepime, our ceftazidime, meropenems, and as well as several other types of medications, macrolides, clindamycin. They're time-dependent in their killing, and so we want to optimize the time above MIC. And so we want the overall medication to be at a serum level of 4 to 5 times the minimum inhibitory concentration for at least 50% of the drug dosing interval. So the bacterial killing is seldom affected by the increasing the drug concentration, but it's more, the peak doesn't necessarily matter as much, it's more keeping it above that substantial amount above the MIC for a greater period of time. And so the best way we know to do that is to actually administer medications via prolonged infusion. So this, if we look at, this is administering Zosyn via prolonged infusion, piperacillin tazobactam. So if we look at giving it over a 30-minute infusion, as we'll often see done as recommended by the package insert, just very quickly, 30 minutes, our probability of target attainment based on the MIC is relatively good. But when we do that same, doing a 4-hour infusion, 3 to 4 hour infusion, we're getting just substantially better increased. We're getting 100% of target attainment up to an MIC of 16, which would even be considered, most likely be considered intermediate by most, intermediate or susceptible depending on the medication or on the drug. But largely the prolonged infusion is what helps us to optimize that relationship, and it's been shown in the literature to improve clinical cure rates and the rates of recurrence using a standardized, we do 3 hours here at Brigham and Women's Hospital, prolonged infusion. Another example is same general concept, meropenem. I had another one where the package insert will say administered over half an hour, but if we administer it over prolonged infusion, that time above the MIC is actually expanded by 2 hours. So another medication, like I was saying, to optimize our PK-PD relationship is insulin, because insulin is extremely kinetic-based and you need to think physiologically. So on top of the absorption issues that we covered earlier, medications like NPH, Detamir, Glargine, all have regular, and then our short-acting insulins, say our Lispro and Aspart, they're all severely different in their absorption and their duration of action. So it's important to kind of structure say a longer-acting insulin or an intermediate-acting insulin twice a day with a rapid-acting or a regular insulin, depending on the patient's source of glucose. Now, obviously, if we're in the ICU, hopefully we should be using primarily intravenous insulin in the acute phases where subcutaneous absorption may be decreased, and it's important to basically form an intravenous regimen from a standardized, protocolized way that could be safe and implemented across the hospital. And all physicians and nurses should be trained and assessed on that training regularly. And really the best way to maximize your intravenous insulin therapy is to monitor very aggressively. 1 hour is best, 2 hours if possible. The half-life of intravenous insulin is only about 6 to 7 minutes, so they're really, if patients are left too long, they could be markedly hypoglycemic for a long amount of time. Also, intravenous insulin, as we all know, is related with intracellular shifts of potassium, so it's important to be aware of the patient's potassium. So in general, my conclusions that critical illness may result in various clinically significant changes in pharmacokinetics, and we should be monitoring pharmacodynamic goals for clinical effectiveness and adverse effects. It's paramountly important. Frequent evaluation and adjustment to therapies are crucial as the course of critical illness evolves, and alterations in the pharmacokinetics and dynamics can vary widely depending on the nature of critical illness, concurrent disease states, and the treatment modalities that are utilized. So I'll go on to my questions here. Question number 1, which of the following is true regarding metabolism and elimination of commonly used drugs? A, phase 2 reactions which occur in the kidney are responsible for most clinically significant drug-drug interactions. B, a drug's half-life is the amount of time necessary for it to achieve steady state in the body. C, the ionized fraction of drugs is reabsorbed by the renal tubules back into the systemic circulation for metabolism by the liver. D, hepatic enzyme inhibitors increase the half-life of drugs subject to hepatic clearance. E, cytochrome P450 related metabolic capacity is consistent across different individuals. And the answer here is D, hepatic enzyme inhibitors increase the half-life of drugs subject to hepatic clearance. So we can run through quickly. A is incorrect. It's mostly phase one reactions occurring in the liver are likely responsible for most clinically significant drug interactions. So things like our CYP inhibitor inducer substrate relationship. B is incorrect because it actually requires 4 to 5 half-lives to reach a steady state in the body for most medications. C is incorrect. The ionized fraction of drugs is reabsorbed by the renal tubules back into the systemic circulation for metabolism by the liver. It's usually the non-ionized. The ionized fraction is usually excreted. And E, CYP-related metabolic capacity is consistent across different individuals is incorrect. It will often vary based on several patient-specific factors and just population in general. Ethnicity can play a major role in CYP function across individuals. Question number 2, which of the following is true regarding the effect of physiologic derangements on medication effects? A, cardiovascular derangements alter systemic circulation of transdermally and subcutaneously administration, but not their absorption. B, fluid retention in heart failure decreases the volume of distribution of hydrophilic drugs due to third spacing. C, insensible losses from burns decrease the volume of distribution of hydrophilic drugs. D, temporary abdominal closure decreases the volume of distribution of hydrophilic drugs. Or E, respiratory failure can alter hepatic clearance of medications. And the answer is E, respiratory failure can alter hepatic clearance of medications. The respiratory failure can lead to sequelae such as, say, decrease in cardiac output or alterations in blood flow, both of which will have impacts on the amount of blood flow to the liver and thus will change the hepatic clearance of medications. We think about why the others are incorrect. They're mostly just opposite. Cardiovascular derangements certainly can alter systemic circulation of transdermally administered drugs, but they will also substantially alter their absorption, as we talked about throughout this talk here, that the absorption of these routes is not great in critical illness. Fluid retention in heart failure decreases the volume of distribution of hydrophilic drugs due to third spacing. It'll actually increase the volume of distribution of hydrophilic drugs due to the large added volume of distribution in this disease state. C, insensible losses from burns decreases the volume of distribution of hydrophilic drugs. It would actually increase. It would decrease the volume of distribution of hydrophobic drugs. D, temporary abdominal closure decreases the volume of hydrophilic drugs, and that's the opposite here.